I, prom I promised to find a speaker about library services. However, it was not possible to schedule an informational meeting over the summer, so tonight is the first opportunity. I'd like to introduce Michele Kraft, who is the library director for the Cleveland Clinic Health System and coordinates access to library resources and services for 19 hospitals and over 300 outpatient facilities in the United States. Currently, she is co-editor-in-chief of the Journal of the Medical Library Association and is on the Journal of the American Medical Association's Library Advisory Board. Previously, she served on the New England Journal of Medicine Library Advisory Board. She was elected to the Medical Library Association's Board of Directors and later was elected to serve as president of the Medical Library Association. Throughout her career, she has researched and studied the importance and impact of medical librarians within healthcare. She has a commitment at 5:30, so there will be a hard stop to this portion of the meeting at 5:05. I'm pleased to say she has agreed to make this talk available on our website. Michele?
Hello, everyone. Okay, I'm going to try and share the screen. And let's see if I've got it. All right, can you see my screen?
Yes.
Great. Okay. Thank you for having me to talk about the impact of medical libraries and librarians. I often use the term medical libraries and librarians interchangeably. So I'm not biased towards the books and the people. They're all working together in my mind. It's a symbiotic relationship. So let's jump right into it. Impact by the numbers. And let me see, let's advance. Okay. So there was a study done in the VA by hospital health professionals in which they looked at how the impact of health librarians and medical librarians within the VA impacted those health professionals in their patient care. And that study revealed that 95% of the health professionals said information that they had gotten from the librarians was helpful for patient care. It reinforced the mode of treatment 89% of the time, altered the mode of treatment 49%, helped them influence and advise to patients or families 49%, influenced the choice of drug treatment or drugs at 30%, and affected the choice of tests about 16% of the time. Now, that was a smaller study with the VA. There was a much larger study done, and that was a multi-hospital study with 118 hospitals and approximately 16,000 participants. And so if you look at that, you could see that mostly the percentages, when they asked how the information provided from a medical librarian impacted their treatment of patients and what they would do, it almost very closely mirrored the VA hospital. So this was a much larger study that really validated the results of the smaller study. Again, 95% of the time, it helped them inform their clinical decisions. They changed their advice to patients 49% of the time, so influence the advice of patients and families. It changed their choice of drugs 33% of the time. So in the VA one, it was 30%. Changed the diagnosis. That wasn't something that was talked about in the VA, but that was 25%. And it changed the choice of tests 23%. In the VA one, it was 16%. So it's very close. A lot of the things were very similar in that kind of thing. If you look at more of the numbers, there was more studies done where a librarian contributed on morning report led to decrease in length of stay by about 2 days. So it reduced the hospital charges by about $3,000, a little over $3,000. And that was back in 2007 numbers. So that would probably be a much larger increase in the hospital charges. So if you're thinking about people who not only this is charges by the hospital and what they're doing, but the people who are actually in these hospitals and the family members who have to handle the billing and the costs of this. A lot of people are afraid to go to the hospital because of the impact of the cost. And if we can help keep those costs down. That also helps them. A librarian also was helping to help save healthcare professionals approximately 2.5 hours per person. My previous boss, when I was a librarian, she used to say, I can sew on a button, but you wouldn't want me to close. A lot of I tell doctors, I went to school. I specifically went and learned how these databases are created and indexed and actually work, so that I am able to, and all of my other librarian colleagues are able to really pull out and tease out the information that people know. It's just we are different types of specialists. And so by relying on different types of specialists, medical professionals are able to save 2.5 hours per person. So we have a little bit about the actual numbers. What we also get is some information about the stories behind those numbers. So for example, with the first one, there was a librarian who actually saved a lot of money from the legal case. A former patient was suing the hospital for malpractice and due to a surgical mishap that occurred. The surgeon and the hospital indicated that that actual mishap was a known risk for the procedure, even though they had never seen it happen before. The patient's two expert witnesses had testified that the mishap, in their opinion, constituted malpractice. And the librarian was asked to do a comprehensive search to see if there was any surgeon that had reported this type of mishap. Previous searches by the legal department couldn't find anything helpful. So the librarian did a search, found approximately 10 articles specifically on that mishap, and one of which was authored by the specialist on that surgical procedure. That actually changed the outcome of the case, and they were actually able to settle the claim for considerably a lot less because it wasn't considered malpractice. The second one that a librarian reported, they had a gastroenterologist who was an occasional user of the library services. He had a patient in the ICU with a problem that was stumping him. He came to the library, gave them some concepts and some details to search on, and the librarian just recalls it was something like bleeding internally. The person looked really bad. So she went to work looking for those information. She obviously had more information than I just said, bleeding internally, but she couldn't find very much on what she was given. But she did find one or two articles that looked pretty relevant that she delivered to him in the ICU. He later came back the day or two later and told her that those articles actually were extremely relevant and saved the patient's life, and thanked her for that. And then finally, we just one last example. A librarian colleague bumped into a nurse who was doing research for the other day. She was doing research for the other day. The nurse thanked the librarian for all the work she did on INR, which is international normalization ratio levels, and Coumadin in patients with COVID-19. It turns out COVID-19 can lead to abnormal INR levels. And so that information that she was able to find led to the change in practice and treatment of patients in the hospital. So not only do we have the actual stats about how librarians and their services can provide services and help really with patient care, but we do have some of those impact stories as well. The unfortunate problem is we have a loss of hospital libraries. The National Library of Medicine in 2006 estimated that there were only about 29 to 34% of the hospitals had library services. In 2007 to 2017, between that time period, the Medical Library Association estimated that there was a 30% decrease in the medical libraries. So what small amount of libraries, hospital libraries we had in 2006 continued to decrease throughout the 10 years following 2006. So we're really seeing a change in hospitals and their libraries. The reason why we're seeing hospital libraries going is honestly, we are not considered a revenue generating department. Even though we are able to show that we help patient care, it's just we are not charging for our services. There's no way to charge back, so we are not considered revenue generating. And hospitals are in a bit of a crunch. And that's kind of saying it lightly. Approximately half of US hospitals ended 2022 with negative operating margins. and some are stating it's quite possibly the worst operating margins in 20 years. Expenses rose 7% from 21 to 22. And more patients are seeking care outside of the hospital setting. As I mentioned, the costs with going to the hospital, more patients are looking for care outside of the hospital setting. And more patients are being seen in the primary care setting. So we have the hospital numbers. Now we're looking at the physician numbers. AAMC reports there are 938,966 total active physicians as of 2019. And then they also, in Becker's, they reported that in Massachusetts in 2020, there are about 32,000 active physicians as a whole. That's not faculty as in medical faculty, it's just active physicians as a whole in Massachusetts. The AAMC reports there are a little over 193,000 full-time faculty at U.S. medical schools. Within Massachusetts, that's 13,000 full-time faculty. So approximately half, and we use that a little bit loosely because some of these numbers are a little wiggly at times, less than half of your Massachusetts physicians are full-time faculty. Of those, we also have the 159 hospitals in Massachusetts, according to Definitive Healthcare. Those 61 of those are considered acute care. The rest of the 159 are made up of psychiatric, specialty hospitals, and rehab, that kind of stuff. Of the medical libraries in Massachusetts, this was a little bit difficult of a number to come across. I was able to find the Massachusetts Board of Library Commissioners special library list, which listed medical libraries. And when I looked on that list, they had about 22 listed. However, I did notice that they eliminated or did not have some of the larger medical school libraries. So I included those. So I came with approximately 30 medical libraries across Massachusetts. That number could be a little bit different up and down because sometimes some of the larger medical libraries will consider branches as one library, or they might consider them as two libraries. But when you look at this type of physicians by the numbers, you see that the two primary ways that physicians are able to get library resources is either through being faculty at the medical schools or through their hospital. Well, when we look at that, we have approximately only 13,000 physicians have access through their medical schools. And then the rest have access through their hospitals that they are a part of. However, with 30 medical libraries and 60 acute care hospitals, we're talking half of the hospitals don't even have a medical library associated with them. So we have some chunks of people, a lot of chunks of physicians that don't have access to library resources or librarians. That is further expanded when you talk about nurses, physical therapists, dentists, and other healthcare professionals, because nurses tend not to be faculty at any institutions. They also are not always the first to be thought of as information needs people from an administrative hospital standpoint. So that kind of gives you a little idea about the numbers from that side of thing. So library access. If you've seen one medical library, you've seen only one medical library. We are all extremely different. And while we all have medical library resources, our access models are all different. Access to online resources is probably one of the most requested access points that that people want, but it's probably the least allowed service that we give to what I would say other users. And by other users, it could mean part-time or adjunct faculty do not have access to the medical school's library, online library resources when they're off campus. Community physicians with privileges. I can say unfortunately at the Cleveland Clinic, if you are not a Cleveland Clinic employee or physician, if you are a physician that is a community physician that has privileges, but you are not employed by the Cleveland Clinic, You do not have access to my online library off campus. You can walk in and use us, but you have to be on the hospital premises to be able to use us. That is a huge barrier for a lot of people who are practicing in their offices. And then alumni. Alumni is all over the place. Some medical schools allow alumni to have access. Some allow them to have limited access. Some don't allow any access. Almost every hospital will say no access for any alumni. So that's kind of where we are. It's all different ways of different access, and that you really have to scotch tape it together. Libraries are investing more heavily in ebooks and online resources. As we mentioned, I am the medical librarian for over 19 hospitals and director for over 19 hospitals and 300 outpatient facilities. I buy a regular print book. It can't be used by all of those people. I do buy some print books, but we are investing heavily into ebooks because that can be used by the most people and across the system in the most efficient way. Unfortunately, ebooks cannot be borrowed via interlibrary loan. For example, and we still do this, but in the past, before online resources were really readily available, you could say, oh, I need this book, but the library doesn't have it. And the library would go and contact another library that has it, and they would ship it over and you would borrow it for a period of time. That's not possible with ebooks. The best that we can do is possibly due to copyright rules, we can do like basically copy a chapter and print that off via interlibrary loan. There's also and I don't have a bullet point for this, but there's also a growing trend within some journal publishers to restrict interlibrary loan of articles, journal articles. I have had various different publisher license agreements that if I did not go through those with a fine-tooth comb, I would not have found that they are restricting my ability to loan those articles to other hospitals or other medical schools that don't have access to that journal. And that is the bread and butter of a lot of libraries, is exchanging those journal articles so that all doctors' clients can access and get those resources. Go next. So the Medical Library Association actually did an insight initiative in which they looked at the difficulties that and the barriers to find clinical information, accessing clinical information. And what they did was they invited medical professionals, publishers, librarians, all to this insight initiative where they discussed the barriers that people are running into. And they were able to figure out 8 pain points that all the users said that they experience. Obviously, time. We talked about the time in which a librarian can save time. Access, dealing with the multiple barriers to access, multiple personal passwords. Awareness, they're not aware of what's available to them. Paywalls are a really big problem. Financial limitations of the institution, but also the actual individual clinician. And then integrating these resources into the areas that they can use. People are overwhelmed with the amount of resources there are in there. Like I said, the librarians are really good at, we learned this stuff when we went to graduate school on how these databases were developed, and we're very good at picking out things that we need. Y'all went to schools for different other things, and we are understand the resource and are able to handle the deluge of information a little bit. And then the platforms, all of these resources are on totally different platforms, and we have to try and bring them. Most of these pain points hit everybody, but they're extremely noticeable for people who have limited or difficult access to libraries, people who are not associated, those other users, the alumni, the hospital community physicians that just have privileges, sometimes the adjunct faculty, those kind of people. Those are people who are duct taping together their access, but having to navigate these pain points. So some of the people say, well, open access will fix it because open access makes things available to everybody. Unfortunately, open access will not fix things. I mean, it's good, and I'm glad that things are being published and open and freely available. But there was a study done in which only about 28% of articles with a DOI, and a DOI is the digital object identifier. It's a string of numbers and letters to provide the permanent, it's like the permanent URL for an article. And theoretically, it's more stable than a URL. So like back here at this slide at the very bottom where I have a citation, the DOI that says 10/15/51/95, that's the DOI. That's like the permalink, so to speak, for the article. So only about 28% of articles that have a DOI are actually are considered open access, and this was of 2018. So this is something that is a concern because DOI tends to have newer articles. They're not the older articles. Open access tends to be newer articles. Much of OA is federally funded research articles, and review articles, while research articles are important, the review articles, the editorials, the clinical pearls, the instructions articles, they're typically not OA. And so that's what a lot of the bread and butter of treating patients, understanding how to look at things. That's what a lot of the caregivers or clinicians are using. And that's not all very open access. Here's a brief, and it's a lot of colors. It's very fall inspired, I guess. This is a proportion of OA open access articles by publishers for the most 20 prolific publishers. And there's colors, and I'll explain the colors in just a second. But all of those colors represent some type of open access, with the exception of gray. Gray means they're closed. That means it's available only to subscribers or subscribing institutions. So while the number of open access articles in Elsevier has the most articles published and the most articles, in open access, if you look at column B, that's the proportion overall of their published articles. So they have less than 50%. I would basically, squinting at it, I'd say they're about 28 to 30% of their articles are open access. The rest of their articles that Elsevier publishes are closed and they're subscription only. So while the number of open access articles in PLOS is smaller than Elsevier, the entire collection of PLOS is OA versus the tiny fraction of Elsevier. And with the exception of Oxford University Press, Nature Publishing, IOP, PLOS, and APS, publishers aren't even hitting 50% of their content is OA. And one of the things to think about is there's a lot of journals that make their articles available after a certain amount of time. That is not considered open access. So I'm going to go explain the colors now. Gold, which you'll see, or the yellow, is an open access journal that is completely open access. It's indexed by the Directory of Open Access Journals. That whole journal is open access. It's free to access to anybody. Green is a subscription access journal, but they allow the author to deposit a copy of their article. Sometimes it's like the prior to final copy edits, final version, in an open access repository. So for example, their medical school repository, those kind of things. So it's not really an open access unless you know to go to the repository, because if you're going through the subscription journal, it isn't going to be open access. Hybrid, this is a journal that is it's a subscription-based journal, and certain articles the authors have paid for open access. So those articles within those journals are available. So you'll have a journal that's a subscription journal, and some of the articles will be closed and available only to subscribers, and some of the articles will be available to everybody. I kind of liken this to like your local online newspaper, where you go online and you look and you're like, some of the articles are free and some of them have that little lock. Unless you have a subscription to that newspaper, you're not going to see that article. Then you have bronze, which is free to read on the publisher's page, but they just really don't have an identifiable license. And those are kind of out there. They're open access, but it's very unclear as to how they fit in the thing. And then gray is closed. And those are all other subscription articles. And like I mentioned, there are journals that, yes, they make their resources of their articles available after a certain amount of time, but that's not considered open access by definition. New England Journal of Medicine allows their original research to be free after 6 months from the date of publication. However, they do not currently offer the ability for authors to publish an OA article and make it immediately available. So as defined by the Directory of Open Access Journals and the open access industry, New England Journal of Medicine is not an open access journal. The articles are available after 6 months of the from the date of publication. But if you're interested in the most recent articles, you need a subscription. So here's another way of looking at OA. This is the percentage by discipline. Biomedical research, which is not always very helpful to the average practicing physician, that does have the most open access. They're almost at 60%. Clinical medicine is just under 50%. So a good 40% of biomedical research is closed and only available to subscribers. Clinical medicine is 60% or a little bit more. So there's other workarounds if the article isn't available via open access. However, some of these workarounds are not what I would consider valid workarounds. Sci-Hub, which is a free online resource where people are able to get free articles. That's actually where people provide their usernames and passwords to their institution to get access to articles. So it's actually run by a Russian national. It's circumventing copyright. We aren't quite sure what they're doing with these usernames and passwords to all of these universities and other areas, hospitals and other areas of institutions. But in order to access articles, you're providing those kind of information so that they can go and get those articles for they have a collection of them. At worst, they're unreliable. I'm sorry, at best, they're unreliable. At worst, they can be very nefarious, and there's concerns about whether cyber attacks can be using some of this information from all these places. Google Scholar, it's great for a quick query, but it doesn't have a robust search engine for the ocean of information that's out there. As a medical librarian, and I use Google Scholar, I find it really a pain in the neck to find a glass full of water that I'm specifically looking for in the ocean of water versus the drop. I mean, it's just so much stuff, and their search engine is really poor. You can't do a lot of things that you would consider of a basic search engine. ChatGPT and AI, I have a lot of hope and promise for that, but we're not there yet. One of the big things is, aside from the fact that ChatGPT, makes up things, it can't access paywalled information. So all of these journals that are behind paywalls, it's not accessing that information correctly, or it's making it up. It just looks at the abstract and puts those things together. The best way it just was described to me about ChatGPT is that it's like your spell check on steroids. You know, when you're on your phone and you're trying to do something and you're like, oh no, that's not the word I sent. It's using predictive software to predict the actual words that you would be choosing. ChatGPT is the exact same thing, only on steroids, where it's using predictive software to predict the next set of words and sentences that are based off of the query that you put in. It's not doing any analysis or thinking through things. So it's getting all that information. We actually tested it in my library just to make sure. I asked it a question and asked it specifically about a question on an article that was behind a paywall and was published after ChatGPT's data. So like they said, the data was from 2022, I want to say. I chose something that was from last month, or the month that I was testing it. It made up all this information saying about the article. And then when I queried it and said, hey, this article was published in 2023 and it is behind a paywall, it was like, oh yeah, my bad. I just kind of used what I had information wise. So it contains a lot of biases and wrong information. There's published studies in which African Americans actually receive less pain medicine, and ChatGPT has been known to say, in when it's crunching through those articles, to say African Americans need less pain medicine. And that's not the case. It's they're underprescribed, but it's not coming through in the ChatGPT way. So right now, while ChatGPT and AI as a whole, I think I view that as like the Google that we had in the past. It's not there yet. Medical librarians, as we know, save time, money, and have the experience in finding information. Medical libraries have grown beyond four walls. My actual physical library has actually condensed to be more of a resource area because as I mentioned, we're going to ebooks, we're going to e-resources. The librarians have consultation areas where we work with the doctors, the nurses, and anybody at the Cleveland Clinic on finding information for their job at the clinic. Without having access to a librarian and the online resources that the librarian can access, it's kind of like a tippy table, an uneven table in which you're building your medical decision making. If you have a little bit of information and it's on a simple thing, your table might not tip. But if you're looking and you're starting to pile on stuff, it can be concerning and it can be tippy, so to speak. So with that, I wrap it up and say, any questions for you all about the need for medical librarians and libraries? And I am going to stop sharing so that I can see everybody, if that's okay. Stop sharing. There we go.
Thank you, Michelle. Are there any questions? We have about 15 minutes.
May I ask a question?
Please, David.
Michelle, this was a great presentation, and I have to say that I am dependent upon the librarians at Tufts University's medical library.
Mm-hmm.
One of the things that you were talking about was open access, and I get approached frequently by publishers or editors who would like for me to send them papers that they will publish in an open access journal for the low price of $70 a page or something like that. And actually, when I published my MPH master's thesis, I chose a journal that didn't charge me a publication fee because I had this very strong feeling that the charging of publication fees is more likely to lead to publication bias, because who's going to pay to publish a paper that doesn't show what you want it to show?
Oh, exactly. There's pros and cons to OA as a whole. One of the problems is, like you said, there's high publication fees, so that you get people who don't want to publish something that doesn't show what they wanted to show. And I think we can learn a lot from sometimes our mistakes as a whole in publishing and showing that. The other thing is it also really self-selects to authors who are at universities or places that will support that. And that is showing to be a bias as well.
Sure.
From the publishing side of things, as a co-editor-in-chief of the Journal of the Medical Library Association, we are completely OA. We don't charge any we don't have a subscription, and we don't charge APCs. We, as part of the Medical Library Association, we were looking at the costs of publishing as a whole, and it still is expensive, even with almost everybody being volunteer editors. The only paid position we have is the copy editor. And we have a very simple publishing platform. And still, we have to figure out how we're making up that money. So there are fees, and it is cost. It does take money to do those kind of things. So I could see if you're going to make it be not a subscription journal from a medical side of things, I could see where the fees are needed to publish, because it's not something that's sustainable, just completely making it free, unless you have an institution and an administration that has a really good intestinal fortitude to just eat those fees and the cost of publishing. But what I do know from working with our OA agreements, and we've dipped our teeny pinky toe into OA agreements with the Cleveland Clinic. The process is supposed to be with reputable OA publishers. Now there's a ton of disreputable ones, so you got to keep your eyes open. But reputable OA publishers, it's supposed to go through peer review before they even talk about charges. Then if it's made it through peer review, then they talk about the charges. Now, of course, there's always the disreputable ones who will just say they're putting it through peer review and just stamp it and everything like that. So OA is the wild, wild west right now. And there are still things that are happening, but there's good and bad. It's, as I like to say, technology isn't necessarily evil. It's what it's used for kind of thing.
Joel? You're muted. Joel, you're muted.
Yeah, thanks so much for a really great presentation. I was particularly interested in your data on those slides on the access of what proportion of physicians have it to the medical literature. And all in terms of your survey, I wondered about the methodology that you used to garner that information on the survey. How was that sort of put together?
Are you talking about the
survey
survey
on the access of various physicians and types of physicians to the literature online?
Well, there's the one that had the big square, and that was the MLA Insights Initiative, in which they invited clinicians and medical students, residents, and practicing faculty all together, and they went through that whole thing. So they identified the barriers. The other one, the slide before it, where I looked at the number of physicians and the number of hospitals and the number of medical libraries, I just looked at the number of physicians, hospitals, and medical libraries, because I know as a librarian and having to turn people away, you either have access through your medical school or you have access through the hospital that you are a part of, or you're paying for your own access. I am not allowed to give access to anybody who's not an employee of the Cleveland Clinic. Literally, the license agreements that I sign for every single resource that I have specifically state employee or student of the Cleveland Clinic library, Cleveland Clinic. So if there was a physician who is a private practice physician comes in, they can use it for a walk-in use, which isn't our license, but I cannot issue them usernames and passwords to use this in their medical office. If I have somebody who is in Cleveland and a retired physician, and they are not listed as a certain type of retired physician with the Cleveland Clinic, they have no access. If I have a physician who is, or a dentist or a PA who's at another hospital that doesn't have a library, I can't give them access unless they're physically using things. So that's the two main access points that people have, is through either the medical school or their hospital.
Yeah, well, that's helpful. So in a way, you sort of thought out what classes of physicians might have it available or not, and then you asked the questions of those people whether or not they had access. Is that sort of the way you did it? You sort of
I asked other libraries, library directors, because each set of libraries has their own rules and regulations. Some allow alumni, some don't. Some allow adjunct and part-time faculty as well as full-time faculty. Others only use full-time faculty. It's all over the place.
And what about from the physician perspective? How did you access those physicians to find out whether they did or did not have access? You just sort of looked at a class and asked a couple people whether they had it or not, or how did you do that?
That is primarily from my experience within the Cleveland area, but also based off of the information from the MLA Insights
Got it.
thing.
Okay, thanks. Thanks a lot.
Mhm.
Ken?
So great talk, very fascinating. I really enjoyed it. I have one question with respect to what you might believe is the future of medical libraries. It seems that the cost of various subscription services might be prohibitive for any individual library to do. Are you seeing any networking where various libraries are networking with others, where each library has their own niche, the endocrinology niche, the psychiatry niche, and then teaming their resources together in order to be able to allow access among all their members to that information?
Yeah, that's what we call library consortia, where groups of libraries pair together to try and pool their money to access all of the resources that they would like, or other niche areas. However, and we do have that, and that does represent a drop of savings. Unfortunately, these journals and these publishers know they're the only game in town for those unique resources, and they charge based on, and I'm not as familiar how they charge in the academic medical world, the universities, but it's oftentimes by faculty and number of students. And the hospital world, they charge by the number of FTEs in a certain resource, or the number of staff, faculty staff, kind of physicians, and the number of beds. There's really not a Costco for library resources where bulk purchasing and we can just get a discount. We do that on a limited basis from the Cleveland Clinic. Like I said, I have 19 hospitals, so I'm able to leverage some of that purchasing power. But for example, I'm not able to get several different resources, and I won't say it because we're being recorded, several resources, even despite the fact that I have 19 hospitals and I can get some money from here and there, because they actually literally count the number of beds across 19 hospitals. And so hospital A has 100, hospital B has 1,500. I'm still paying for the amount for 1,500 for the hospital B, and I'm still paying for 100 for hospital A. These companies don't see a huge value in discounting their resources because they're the only game in town. Like I said, we are able to see some minuscule things, and sometimes my minuscule wins are I'm able to negotiate it, so I'm only seeing a 2% annual rate increase versus a 7.
Jay?
May I ask you a question? You mentioned among the area of the importance of the librarian is that you are able to show that the patient's length of the stay was shorter. But we also know that changes occurred in the hospital administration and the changes of the whole hospital management. Could you explain more how that 2.5% decrease in the hospital stay was related to the librarian? Because this is the cost saving, and that's very important part of the medical practice as far as the saving is concerned.
For that one, I'd have to get really deep into it. I'd have to look at the article that did study it, but I do know that article looked at librarians who were rounding with physicians. So the librarians who specifically went on rounds were able to show that they were able to decrease the length of stay for the people that they were on rounds with. I would have to look at the article and really go in depth to see their methods, to see how they validate it and things like that. I haven't memorized that. I'm sorry.
No, thank you so much. I am very much interested to know about that, because as far as the cost is concerned and cost saving, including cost to the library, maybe that's one area that we have to investigate further.
And I think I have the actual citation in the slides. I'd have to look at that a little bit more to give you the let's see, that one was done in 2007, so it's older data. But I can paste the actual citation in the chat real quick. Hold on. There we go. And it doesn't include hyperlinks, but you get the citation itself.
Okay, excellent. Thank you very much.
Nikki, do you have a library that you can use to look that up?
Well, the nice thing is that's the Journal of the Medical Library Association, so that's a freebie.
Jay? You're muted, Jay. Jay? You're muted.
Dr. J, you have to unmute.
I can't hear you because you're
I can't
muted.
hear. We'll
You
go
have
to
to lip
Jim.
read.
Jim?
All right. Sorry, Dr. J, you're on mute. If you unmute, I'll stop.
I don't
so
have
just-
lip reading abilities.
Thank you for your presentation. I guess my question for an organization like the BML, where you said most physicians either have access, like if they're at BU or Tufts or Harvard or whatever, you have the gap that you identified in your survey. Is it viable still for an organization to think about providing electronic access to those who don't?
I think it is. However, you guys need to really sit down and figure out what your area, the low-hanging fruit, who you want to serve. If you're looking at specifically just physicians, all of those kind of things, you need to really actually have your goals and targets and things. Rick and I were just chit-chatting, via email and things like that about how you would market this stuff to the different people because if you have all this stuff and nobody uses it, that's a failure. I mean, as I always tell my staff and my physicians, they're like, "Oh, I'm so sorry, I'm using this a ton." I go, "Oh, dude, use it as much as you want. I pay a lot of money, you use it." So when you want to market this stuff, you need to figure out what your target audience is. You need to figure out what their target wants and needs are and really start baby steps and grow from there. It's kind of like starting a whole new, it's actually starting a whole new hospital library from scratch. And I have done that once before years ago. It takes time and it's baby steps, but if you can do it and market it and really become and find your advocates and then build upon your advocates, it can work.
Okay, thank you. I see Dr. J unmuted. Sorry, Dr. J.
Jay? We have 2 minutes.
Okay, briefly. Firstly, thank you for a very informative, excellent talk. Thank you. Can you hear me all right now?
Yep.
All right. The other is two-part question. The first was partly addressed by an earlier question, and that is, do you have an idea, an estimate of the population that doesn't have access to the services of a librarian and of electronic access to primary sources? How many are actually want or needed? Because we've been looking for that, and that's a tough one for us.
That's
and the
just,
second half of the question, is to see what your projection of the future is, given the high cost for access, and also to maintain a library library service is a high cost. Where do you think it's going? Because this has been more or less in the same place, if anything, getting worse in the last 15 years or thereabouts. So that
okay. So for the first part, that's extremely difficult to actually study and research. Rick and I have been emailing back and forth. There are no studies that have, at least that I am aware of, I'll put that little caveat in there, that I am aware of that have studied what happens to the doctors, the nurses, when they don't have library resources. And the problem is when the library closes because the hospital closed it, there's no librarian to study it. Or if the hospital closes completely, there's no librarian and there's no doctors to even study. And so it's very hard to find that. I know various medical librarians have been trying to figure out a way. Prior to the pandemic, I was actually working with a group of librarians where we were going to actually survey basically chief medical officers. And I had the support of my chief medical officer it would actually go out under him, so that people paid more attention to him than the librarian. But we were going to survey chief medical officers within the United States, asking them, how did they find information? Did they use a library? Do they have a library? That fell through because of the pandemic. And quite honestly, because of the pandemic, people are stretched thin when it comes to research now. They're just not in that frame of mind and being able to do that kind of stuff as a whole. So that's the area that it's very difficult to quantify, who has access and who doesn't. A lot of your doctors and nurses think Google is just fine. And sometimes, depending upon the question, it may be. And so they're not expanding and understanding from that perspective. The second question was, where do I see the future of libraries and the costs? I see the future of libraries actually, it's going to be very rocky. We are starting to see, well, I don't say we are starting to see, we have been seeing within the last couple of years, a lot of your hospital systems buying up smaller hospital systems. When these hospital systems buy up other hospitals, they're totally merging the departments and getting rid of departments. A lot of times, I know of several librarians whose hospitals were bought by larger hospitals, and there's one librarian helping 20 other hospitals. And 5 of the hospitals have resources, 3 have half of the resources, and the rest have nothing. And they are arguing, or let's say advocating for their hospitals to actually contribute access. I'm also seeing medical schools now. This is the part where I'm starting to see more of medical schools buying hospitals, and also out of state hospitals. And that gets really wonky because the hospital thinks that the medical school will solve all of their information needs, their library needs. They're like, oh, the librarian will solve this. The medical school will pay for our resources. We don't have to pay for this resource. We don't have to pay for this large resource. The medical school isn't licensed for that. They have to turn around and license all the resources to the hospitals. Most of your hospital administrators are MBAs. They are not a lot of them are MDs or DOs with an MBA. So when you're talking to administrators and hospital administrators, the MBA person doesn't understand the academic medical center side of things. And when they say, oh, well, your faculty have access, the administrator goes, perfect. Those are the only people who need the resources. I've just saved us a bunch of money. So I think it's going to be a lot more condensed. I think it's going to be a lot more bumpy. I foresee some attrition in the publishing world. It's very cutthroat as it is right now. So it's difficult. And I think in a way with the artificial intelligence, I kind of see that actually in the future, we're talking future, helping it overall, because I can see where if you design a really good AI to really data mine your online resources and combine that with your electronic medical records, you can really combine that kind of stuff as a whole and then use it to synthesize, the clinician would use their brain to synthesize what the AI produced.
Jack, we really should
Thank
go
you.
into the election. You have a very short question. You're muted.
Just a quick question. I think our long-term goal is to play a significant role in universal free access in the ocean of health knowledge, information that's going to be useful both to the public and to health professionals. And that really is more than doctors, the health professional community. How can we, with limited access, but with a lot of real keen interest in moving this whole field of informatics forward, what do you see us, the trustees of the Boston Medical Library, and our members, doing to play a significant but of course limited role in advancing, in many ways, the world now access. You know, what can we do that's tangible, is going to encourage our caregivers and our patients to help them be more health information literate?
I think you guys are actually well positioned as, you know, part of the Massachusetts Medical Society, Massachusetts Medical Society, because you already have that as part of your being, so to speak. So you have the gravitas. So what I could envision now, what you guys want to do could be different, but one of the things that I could envision you guys doing is there's a real problem right now with fake news, and I don't see that going away. And but there's a real problem with people understanding medical literature, medical information. And so if this is an area that very few organizations do well and do in a large scale, is take research and write it to the level of the average person or even the average physician. There are a lot of genome studies that I read it and I'd have to read it 10 times and I only get about that much of it. And I would think that I'm higher, my understanding of medical literature is higher than the average person, but I'm not I'm not at the level of a geneticist or something like that. So having those kind of resources to possibly work on those kind of specialty things and really help drive people to better understand healthcare and health information so that it's available to not only the public, but also the average physician who's not the expert in other areas. And if you're creating that own content, that's yours. And you don't have to worry about licensing it. You'll have to license the resources that you use to read it, to write about it. But if you're writing and creating your own content, that's really valuable. And then that also, if you really start to do that well on a larger scale, that's where you get the Today Show, Good Morning America, those people saying, according to this study was done, but this is the layman's term, and they won't use layman, but you know what I'm saying? This is what this group said. So this is what you need to pay attention to. So I can see that as being a really good opportunity that I don't think a lot of areas have done, especially in the area of fake news. And fake news is such a problem these days.
Thanks, Michele. It's very insightful.
Thank you very much, Michele. I really appreciate you doing this for us. I'm especially grateful that you've allowed us to tape it, and it will be posted on our website. As all of our lectures are, it will be made accessible to the hearing impaired. I think we need to move on. I'm sorry.
I just wanted to give an example of effect of the library on and librarian and availability of access to the public. And one of the area, I wanted to say that I'm a surgeon, so I do surgery. And one day I had a patient who came in and gave me the literature from New England Journal of Medicine and said, this is what I want you to do for me. So I think we have to, and believe me, this was a complicated case. And she brought the whole thing and said, I want you to do that. So I think that the public view and public awareness and the availability of the medical literature toward the public also is an important aspect that I am not so sure how good we are to really guide the network to make it available.
Thank you, Nikki. I think we do need to move on. Michele, I really appreciate this.
Thank you for having me.